So we know from the Litro study that a cutoff of 6 millimeters squared is what you're going to use for the area to determine whether or not to treat a stenosis in the left main or whether you can safely defer it. We know that patients that have a MLA of greater than or equal to 6 millimeters squared have the same outcome as those that undergo revasc if they have an MLA of less than 6 millimeters squared. So you can safely defer those with greater or equal to 6, and if it's under 6, you're going to go ahead and treat. Now let's talk about the two types of lesions that you're going to encounter. The less commonly encountered lesion subset are ostial and midshaft left main lesions. In comparison, there's also distal left main lesions, which are more readily encountered and have some own technical difficulties that you're going to have to deal with. So when you look at an ostial left main lesion, one of the main things is you have to have your catheter completely coaxial. If you don't have it coaxial, you're going to overestimate the degree of stenosis. So the thing is to make sure that it's always coaxial so you can appropriately determine if you actually need to treat the ostium or not. Moreover, the types of lesions you're going to find at the ostium tend to be more calcified lesions and those that have negative remodeling, and that has implications on how you're going to treat it. Now, how are you going to size your stent to the ostial disease? And the way you're going to do that is to look at your distal left main reference, okay? Fairly simple, fairly intuitive. How are you going to size your stent if you have a mid-shaft lesion? Again, distal reference of the left main, and you're going to size it to that. So fairly straightforward, kind of intuitive. Now let's go to distal left main coronary artery disease. And we're going to talk a little bit about plaque characterization, a provisional versus a two-stent technique, and then how you're going to size your stents. So Gary et al. And many others have basically shown that distal left main lesions are the most frequently encountered lesions you're going to see in clinical practice. They constitute approximately 70 to 80%. And compared to ostial and midshaft lesions, they're obviously much more complex to both assess as well as treat. So when you look at a distal left main lesion, one of the things you have to make sure is that you do not miss ostial or proximal LAD and circ disease. So you have to do a pullback in both branches. So if you see left main coronary artery disease in the distal left main, you have to do a pullback from both. Angio has a fairly poor predictive value, both positive and negative. Now, the other part is when you have the lesion in the distal left main, you have to figure out what the actual morphology is because your treatment strategies are going to be predicated upon that. If you happen to have thrombus, you're going to potentially need some sort of aspiration in order to make sure that you don't embolize the thrombus. And then if you have calcification, you're going to obviously need calcium modification therapies as well. Now, when do you do provisional stenting? So there are certain things that probably allow you to use provisional stenting. De La Torre Hernandez has been obviously very prolific in this space. And his recommendations are the following. One, if you're just going to do a crossover from the left main to the LAD, if you have a very small circ, so less than 2.5 millimeters, if you have no real circ disease, and that includes a plaque burn of less than 50% on angio, if the lesion in the ostial circ extends less than 5 millimeters, because if it is tight, you can just balloon it and it shouldn't really be an issue. If there's a very wide angle, which may make stent delivery and optimization a problem, then you may want to consider a provisional strategy. And if you have no significant ostial circ disease by Ivus, and by that, if you have an MLA that's greater than 3 to 3.5 and a plaque burn less than 50%, then you don't potentially have to treat. Now, if you're going to do a crossover from the circ to the left main, you have to make sure that the LAD ostium is free of disease and mildly affected by Ivus, and that the circ has a significant lesion in a dominant or a vessel that is at least 2.5 or greater. So what's the strategy here when you're going to stent into, say, the left main into the LAD? You're going to use the reference diameter of the LAD to size your stent, okay? So you're going to use the LAD size, and you're going to find an area that has a plaque burn less than 40%, and ideally close to zero and normal. So take a look at this case. Essentially, you see that there's just a left main disease. Ivus is done into both limbs to ensure that you don't necessarily need to treat. There's more disease in the LAD than there is a circ, so you're probably just going to do a crossover from the LAD into the left main. You see that the LAD has a distal reference of 4 millimeters, so you're going to use a 4 millimeter stent. Now, when you're having a stent that goes from the LAD to the left main, you have to make sure that you have enough length in the left main stent to be able to pot it and to be able to expand it. So you want at least 6 millimeters into the left main, ideally closer to 8, so that you can get a pot balloon in. Now, the other part that you need to know is stent expansion. So if you have a 2.5 left main, 2.5 LAD, and your left main is approximately 5, you can't get a stent from that size to that size through post-dilatation. So you have to figure out which stents you're going to use that will appropriately expand appropriately. Now, the preference for two-stent technique are the following. So if you don't have a small circ, you have a large circ or dominant circ, and there's significant long disease, more than 5 millimeters in the ostial circ with a true Medina 111 or a 011, then you're going to want a two-stent strategy. If you have complex lesion in the ostial circ, if you have a narrow angle, and by Ivus, if the MLA is less than 3 to 3.5 and the plaque burn is greater than 50%, you want to go ahead and use a two-stent strategy. Now, if you're using a provisional strategy, these are the markers of when you're going to have to put in a second stent. One, if you have a stenosis that's greater than 75%, there's a reduced flow, there's a dissection, or use physiology to prove that there's probable ischemia. So let's take a look at this case. This is a case of osteal disease in both the LAD and circumflex, but the calcific nodules are less than 180. And you see that the MLA of the osteal LAD is 3.2, the osteal circ is 3.4. And so how are we going to take care of this? So we're basically going to use the distal diameters to take care of this. So the distal diameter of the LAD is going to help decide the stent that you're going to bring from the LAD to the left main. And then depending on the stenting strategy, whether you're going to use a culotte or a tap or a DK crush, then you're going to have to figure out the diameter for the circumflex. And again, you're going to use the distal reference of the circumflex and then use that to size your stent from the circ. So let's talk about this case here. And what you find is that the LAD with the calcific nodules, again, less than 180, you basically have a lumen diameter of 3 millimeters, both in the LAD as well as the circ. The left main is 4.5 essentially. So again, you're going to need stents that go from 3 to 4.5. Now the problem is there's no stent that goes from 3 to 4.5. The good thing is that you find that essentially the left main, the distal left main is disease-free. And so the disease is really at the ostium. So the operator here chose to do a V-stent and then use a 3/18 in the left main to LAD, just in the ostium of the LAD with a little protrusion, and also in the left main and circ. Now, once you've placed your stent, you have to make sure that you've actually optimized your stent appropriately. So let's talk about how you're going to do that. Let's talk about a one-stent strategy first, and then we'll move into a two-stent strategy. So the minimum area, as we know, originally we thought that 5, 6, 7, 8 is what you want. 5 millimeters squared in the left circ ostium, 6 millimeters in the LAD ostium. The polygon of confluence, you want it to be at 7, and then the proximal left main, you want it to be 8. And we know from the Excel data that really we probably want to go even higher. So we probably want 6 in the circ ostium, 7 in the LAD ostium, and 10 in the proximal left main. So again, this is more work by Dr. De La Torre Hernandez, but essentially the way he describes how Ivus optimization needs to take place here is that you're going to really want an expansion in the left main where the minimal stent area is greater than 90% of the distal left main reference, okay? So for ostial and midshaft, you're going to use the distal left main reference, and you just want to make sure that it's greater than 90%. Now, not all left mains are tubular. Some of them actually become funnel-shaped. And so when that happens, you can accept something that's greater than 80%. And just like any stenting process, you want to make sure there's no problems such as a lack of apposition. You want to make sure it's appropriately expanded. You don't want any proximal stent deformation, which is important, particularly when you're taking care of osteal disease. The stent can bang in and out and actually cause stent deformation. So you have to make sure that that doesn't happen because it's been shown in the Excel sub-analysis that it leads to worse outcomes. You also want to make sure your plaque burden at the distal stent edge is less than 40%, ideally close to 0, and you want an absence of dissection and hematoma. So take a look at this case. The provider thought that the only thing that they needed to treat was a mid left main stenosis. So they put a stent, they sized it appropriately, And when they did a pullback, they realized that they didn't actually look at the ostium up closely. So when they had the stent placed, the MSA was 10 millimeters squared. However, when they pulled back, they realized that the MLA of the ostium is 5.2. So obviously you need to make sure that you disengage your guide, particularly when you're looking at the left main ostium. And then subsequently a second stent needed to be placed, which is obviously suboptimal. Now, when you're going to do distal stenting, distal left main treatment, and you're going to stent via a provisional approach, again, the stent in the left main, you're going to use the same criteria. But you now have to use the proximal left main as your reference for when figuring out when you're doing your left main stenting. So if you're going to do left main stenting and it's a crossover, to make sure that the left main portion is appropriately expanded, you're going to use the proximal left main reference here, not the distal or the LAD. And then in the LAD, you're then going to use the distal reference in the LAD to make sure that portion is appropriately expanded. And again, you're going to want to make sure that it's opposed, there's no stent deformation, and the edges are fine. So take a look at this case. Again, there's a distal left main stenosis, and the way the operator decided to treat this was basically to do a crossover from the LAD to the left main. They put in a 3-5-18. We know that 3-5 stents can easily go up to 4-0, 4-5, 5-0, and 5-5, and some can even go up to 6. So here, after the stent was placed, the operator dilated the stent both in the left main as well as the LAD. However, there's stent under expansion, as you can see, because again, you're going to compare this to the proximal edge. And so then a larger size balloon was utilized, and you can see just from the imaging, not even having to do any calculation, that this is markedly improved. Let's take a look at this case. There is a distal left main disease with LAD disease and circ disease on Ivus, which incidentally you can't really appreciate as well on angio. But what you find is that the distal left main has an area of 5.5, so you know you're going to treat that. There's some disease in the LAD, there's some disease in the circ. The area in the LAD is 3.8, and the circ it's 4. So it's sort of borderline, and whether this should be treated or not. So physiology is your friend here. Physiology is performed, and IFR is performed of the LAD, found to be 0.8. That of the circ is found to be 0.92. So you're probably going to do a single stent strategy from the LAD to the left main. You don't have to treat the circ necessarily. So that's what was done using the LAD reference. A 3.5, it was the reference, and that was used to get a stent. And the stent was a 3.5 by 24. Post-dilatation was done with a pot in the left main up to 4.5, and you got excellent expansion. Now, the one problem is whenever you do something as a crossover from the left main into the LAD, there is a chance that you're actually going to cause some degree of lumen loss. And so you have to basically be able to take care of that. Now, one of the things that you need to know is, at least based on some of the studies out there, that only 1/3 of angiographically jailed circ ostia actually have an FFR that requires treatment. So the vast majority of circs that get pinched, you don't necessarily need to do anything. In this case, the FFR was 0.76, so the operator decided to take care of this with a TN protrusion. Now let's talk about assessing and optimizing the procedure via two-stent strategy. Again, you're going to use the same thing where you're going to use the distal references in your LAD and your circ to make sure that you're getting appropriate expansion. Here, you're also going to make sure that there's no stent deformation at the proximal portion. So in this case, essentially, you can figure out what the proximal reference is, and you're going to use that for the left main portion. Then you're going to use your healthy distal portion in the LAD to figure that out. And then in the circumflex, you're going to use the distal reference here. So what you see essentially is that you probably have a reference of around 5 millimeters for the proximal left main. If you look at the proximal LAD, you have something around 3.5. And then if you look at the circumflex, it's closer to 3. So what you're going to do essentially is use a 3.5 stent in the LAD, a 3 millimeter stent in the circ, and then you're going to probably use a pot that's going to be closer to 5 millimeters here. And this was done via a mini crush. And when you look at stent expansion, both in the left main, you find that the MSA is allows for 97% expansion, the LAD 90.6, the circ 95%, so you're done. So again, I'm going to conclude here, but the use of Ivus can markedly help when performing left main PCI. First, to determine if you actually need to do it, and then B, to optimize your stent expansion. There are different technical considerations when you have an ostial or midshaft lesion compared to if you have distal left main. Ostial midshaft lesions tend to be sometimes easier to treat than distal left main just because you have to deal with a bifurcation. And in larger size individuals, I think we should move away from the 5, 6, 7, 8 criteria and go to the large, quote unquote, Caucasian male criteria. And then with a provisional approach, less than 1/3 of osteosteric lesions tend to be FFR positive, so you don't necessarily need to treat them. And then you should obviously aim for greater than 90% stent expansion compared to the distal references. Thank you so much.